Hi everyone. I hope you're enjoying this Sabah ICU Congress and find it very useful for you. I'm Dr. Abdul Jabbar. I'm a pensyarah perubatan from University Malaysia Sabah. Okay, so my topic for now, for today, this session is keeping all the organs alive except the brain. So you have heard about organ venous congestion from Dr. Abilash and about kidney injury and so on. So usually we talk about to preserve the brain, to protect the brain, but today I'm going to talk about letting go of the brain. We don't treat the brain, we don't care about it, but we care about all the other organs. So what is this all about? Okay, so it's about disease organ donation. Okay, so our country, disease organ donation is very low, and we need to do a lot of work, a lot of efforts to increase disease organ donations. So this organization is quite big, and this part that I'm going to talk about is about organ donor management to maintain the organ. So I'm not sure whether how many of you have been involved with organ donation or organ management or organ maintenance, but if you want to see the concept of organ transplant, you can think of it like a when you go through life, right? So you will have your life will be diminishing like this Pac-Man game, and then after that, when someone gives you an organ like a kidney, when you have been having chronic renal failure for so long, it feels like an extra life. So your life, you will get back the life, one more life, okay, for you to use. Okay, so it's like an extension. That's why people call it the gift of life, the hadiah kehidupan. So the gift of life. All right, so what is organ transplantation? It's a replacement of a terminally damaged organ or tissue with another healthy organ or tissue from another person. Okay, so for this, in this instance, that the kidney transplant, the non-functioning kidneys in the recipient, they will be transplanted. One functioning kidney will be transplanted to the patient, and the other kidney will go to another patient. This is in case for one donor, you will benefit two patients' kidney. With the two kidney will benefit two patients. So what are the organs that humans can donate? Humans can donate the heart, the liver, the lungs, and the kidneys. This is what we do in Malaysia. In some other centers in other parts of the world, they also do intestine and also pancreas. And this four is actually life-saving organ transplantation. There are also life-enhancing organ transplantation such as corneas, cardiac valve, arteries or veins, intestine, bones, tendons, ligaments, skin, limbs, and even face transplantation. So our national transplant waiting list is very big. This is as of May 2019, was 3 years ago. Kidney waiting list was 20,000 people. So liver goes up and down depending on the necessity at that time. And the heart lung end block is even more rare to get, but the demand also not as high as kidney. So this is the number of disease organ donation. In 2020 and 2021, it has been picked up quite fast compared to 2019, but it's still comparatively quite low compared to other countries in our region and as well as in the world. So we are like a bottom part of the organ transplantation. So number of official donor from Sabah in 2019, I had done 3 organ transplantation, solid organ donation in Queen 1, and but it's still we still need to do more to improve the rate of organ transplantation or organ procurement from Sabah. So what are the types of organ transplantation? There are 2 types. One is living donors and one is disease donors. Okay, so we are talking about disease donors today. All right. So there are 2 types of disease donors. One type is donation or donor after brain death. Another one is donation after cardiac death. Okay. So usually donation after brain death can come due to brain injury like CVA, ischemic or hemorrhage CVA, brain trauma, and encephalopathy or primary brain tumor. So all sort of brain injury can come and will lead to patient becoming potential organ donor. So this is the framework of organ donate transplantation. So this is the work that will go through when you want to have an organ transplantation. Okay, first there will be a donor detection to detect the potential organ donor, and after that there will be donor evaluation, and then we'll go on to brain death diagnosis, and then obtaining consent. And after that, after the organ has been procured, then we go to organ allocation, obtaining consent, and they will at the same time, the organ transplantation team will find the organ to be allocated, the recipient, and lastly, it will end at the surgical procurement of the organs. Okay, so from here to here until right before the procurement, this is what is organ donor maintenance, the maintenance of the organs inside the donor's body. Once they have been inside the donor's body, this is what my talk is all about. Okay, so usually when if you have experienced it before in your ICU or in your hospital, most of the time people thought is that once we diagnose the brain death, only we start to properly maintain the organs. No, it's not. It doesn't work that way. Okay, so as soon as you detect a person is potential organ donor, having a very bad brain injury, okay, so as soon as you detect, before anything, before any assessment or whatever, you need to think of to maintain the organ as soon as possible. Okay, even before the brain death diagnosis, because when the brain death diagnosis can come a little bit later, when the patient is already in the ICU, or maybe the transit between from the ward or the ED to the ICU might take some time. Okay, this can lead to worsening of the organ function in the donor. Okay, so we need to start it as early as possible, organ donor maintenance. So how do we do it? Okay, what should we expect when the patient is brain dead, especially when the patient is brain dead? We know when there is potential organ donor, when the patient becomes potential organ donor, we thought this patient might be having or experiencing the process of brain death. Because this is the scope of the talk today. The scope of the talk today, like I said, we want to keep all the organs alive except the brain. Okay. So in summary, when the patient undergoing the process of brain death, there is some physiologic changes during brainstem death that can occur in the patient. This is from the Journal of Heart and Lung Transplantation in 2004. The highest incidence of physiologic changes is the hypotension, which is also actually a hemodynamic instability, diabetes insipidus, followed by DIC, arrhythmia, pulmonary edema, and metabolic acidosis. Okay, so hemodynamic instability is the highest. Then comes the DI. So first we talk about hemodynamic instability. As you can see, hemodynamic instability in critically ill patient can have plenty of etiologies, from congestive heart failure, cardiac injury, metabolic disturbance, arrhythmia, because the patients with the brain injury can come in with trauma, can have chest injury, abdominal injury, penetrating trauma, and so on. So they can have bleeding, they can have fluid under volume, hypovolemic shock, and neurogenic shock, and a lot of multifactorial factors that can cause hemodynamic instability. So you don't think about the brain death only. You need to think about the other factors that comes together with the patient. So we need to assess the patient as a whole, and not only focusing on the brain death. So, but we need to know what is the specific things that happen to the patient with the patient undergoing brain death process. So when we talk about, I already talked about the multifactorial causes of the hemodynamic instability. So, but what is the isolated effect of just brain death alone, not including other etiologies? So these changes can be best, what was described the best by Nowitzki. Nowitzki done several experiments in 1984. Especially, he used baboons to stimulate and to describe and to observe the pathophysiology of brain death. So when he induced this brain death process in the baboon, in specifically for hemodynamic, it has been seen that there is two phases of physiological changes after brain death. Okay, so as you can see here, noradrenaline, epinephrine, and dopamine have sharply rise after the brain death initiation, brainstem death in the baboon. Okay, after that it will drop very fast and will lead to loss of catecholamine. So it shows here by the experiment in the baboon, as well as the observation of thousands and thousands of organ donors, disease organ donors, when they undergo brain death. It has been shown that the patient will develop two hemodynamic phases. With first one is initial sympathetic stomp or autonomic stomp, AS, that the researcher in brain death usually refers to. Like it can be seen here in the baboon, norepinephrine and epinephrine sharply rise, initial sympathetic stomp, followed with subsequent sympathetic loss. So these two hemodynamic spaces, initial sympathetic stomp and subsequent sympathetic loss, both are very important phase that needs a certain specific management and treatment. So remember, on top of these two phase that is initiated or caused by the brain death itself, you have to remember that patient's conditions upon presentation may alter, complicate, or confound these phases, like comorbidities of the patient itself. Patient might be old, already have some comorbidities before, patient having trauma, bleeding, and others at the same time when the patient presented with the brain injury. Okay, so the initial sympathetic stomp can occur from minutes to hours. It started off with when the brain is dying. It's typically described as dying from rostral to caudal. So it starts from pons and midbrain. When the coning occurs, it can cause Cushing reflex, bradycardia, and hypertension. At this point of time, the medulla, which is having the vagal centers, still actively functioning and causing bradycardia. Okay. So when the brainstem further dies, the dying portion, the process will go on towards medulla and the loss of vagal tone, causing sympathetic stomp, unopposed sympathetic stimulation, and the loss of vagal tone when medulla eventually die. So it can cause sympathetic stomp, which is tachycardia and hypertension. So the BP rises very sharply, very high, very tachycardic. So what about it? It's actually very cardiotoxic, and this has been described also in subaortic hemorrhage, where neurogenically stunned myocardium in brain death patient, and also in subaortic hemorrhage patient, there will be cardiac injury, cardiotoxic to the heart. Okay, there can be a cellular and contraction band necrosis, coagulative necrosis, and high incidence of graft failure after transplantation. So when the patient having this autonomic or sympathetic stomp, they will have higher incidence of graft failure, especially for the heart after transplantation. So we want to donate the organ, but we don't want the organ to be dysfunctioning very soon after transplantation. Otherwise, because patient already, the recipient already put themselves to risk to receive the organs, and we undergo a lot of things to receive the organ, especially the heart. And when the patient have this sympathetic stomp and autonomic stomp, it will also be injurious to other vital organs, because the sympathetic stomp can cause severe vasoconstriction without any increment in increase in oxygen supply, and plus the severe vasoconstriction, a lot of blood flow to the organs. It can cause direct injury to the organ, and it can cause tissue edema. Okay, so subsequently, after the sympathetic stomp that can last from minutes to hours, all right. So on average, it's about, based on studies, it will be about around two hours on average. Okay, so sympathetic stomp after the patient underwent sympathetic stomp, which is minutes to hours, tachycardia and hypertension, due to dying pons midbrain and medulla, this transitional state is a transitional state of a dying brain. Okay, so after that, the physiological state will change to loss of sympathetic tone. This is because of the complete brain death, which cause profound vasodilatation. At the same time, there will also be an upregulation of inflammatory mediators causing excessive inflammation. So this complete brain death, which cause complete cessation of catecholamines, central sympathetic outflow just drop, just lost, plus increase in inflammatory mediators being released, cause severe hypotension due to severe vasodilatation. This is mainly due to reduced SVR, and sometimes it may also be explained by relative hypovolemia, and maybe sometimes, but most of the time is due to patient presentation itself, like bleeding, fluid restriction in patient with traumatic brain injury, and it can also be further exacerbated by diabetes insipidus, where patient lost a lot of volumes, and this can cause high incidence of graft failure after transplantation as well. So hemodynamic instability, how do you manage this? So these two hemodynamic phases, the initial sympathetic stomp or autonomic stomp, duration can be short but injurious for the heart and other organs. The best studies is the study done by Audibert. He defined autonomic stomp as systolic blood pressure more than 200 with heart rate more than 140. If you look into other sources, they use MAP more than 100, more than 95, and so on. But this is the best definition of autonomic stomp in brain death. So in his study, patients was divided into two groups, those patients with autonomic stomp and treated, and those patients with autonomic stomp and not treated. And when they compare, when Audibert compare, it seems to be those patients with autonomic stomp, BP go very high, heart rate goes very high. It has been shown this group of patients have better graft function in terms of left ventricular ejection fraction and CKMB in the treated group. In this group, the treatment that was used was esmolol, urapidil, and the ARB, one of the type of ARB, and nicardipine. Other authors suggest to treat if MAP persistently more than 95. You need to treat with short-acting agents such as esmolol, GTN, or sodium nitroprusside. So not all patients will have this autonomic stomp, but when the patient have it and you are thinking about brain death, you need to treat the patient. You need to bring down the BP because it can cause a lot of injury to the heart as well as to the other organs. Okay. And you need to remember, because this patient will definitely goes into sympathetic loss of tone of the sympathetic, you need to treat with short-acting agent. So the subsequent sympathetic loss is the more important phase, and cardiac arrest can occur within hours if unsupported. The management triad consists of hypovolemia, cardiac dysfunction, and vasodilatation. So to maintain organ perfusion, the concept is very easy. You have to remember two important formula. One is organ perfusion pressure, another one is organ oxygen delivery. So this is a global oxygen delivery formula. So we need to remember that we need to have a good oxygen content in the blood. Of course, the saturation must be there, and the HB must be fully saturated, 100% SpO2, and the oxygen content need to be good. And then there will be a good pump function as well, cardiac output. Okay, so when you have a good DO2, so the delivery of the oxygen content and oxygen delivery is considered good. Another one is the organ perfusion pressure, which is dictated by MAP minus AVP equals to organ perfusion pressure. This is the heart, which is the pump. Then it will pump the arterial blood to the organs, and the MAP is the feeding pressure, the upstream pressure, and the downstream pressure will be the CVP, and the difference, the gradient between these two is the organ perfusion pressure, is the pressure that the organ will receive. Okay, so you need to do, when you have a low MAP, low BP, you need to do fluid resusc, you need to give vasoactive agent to increase the BP. You need to avoid fluid overload because the CVP will be high. When the CVP is high, the organ perfusion pressure will be low. Okay, so perfusion pressure will be low. All right. So some other cause of high CVP like RV failure, right ventricular failure, or excessive airway pressure also can cause this. All right. So you do have to remember also most of the organ do have the internal intrinsic autoregulatory mechanism, and they will maintain the organ perfusion pressure around 50 to 150 in the extended range of organ blood flow. So this is to maintain a good organ blood flow. So in the range of 50 to 550 organ perfusion pressure, the organ blood flow will be maintained by the intrinsic mechanism of the autoregulation. But this is beyond our control, because the body control itself the organ level, but what we can control is the mean arterial pressure and the central venous pressure. So subsequent sympathetic loss management can be divided into three: multifactorial, hypovolemia, which is multifactorial in nature, the causes. Vasodilatation mainly in brain death is something like neurogenic shock, because the brainstem is already gone. Okay, so there is no more sympathetic outflow. So it's like a neurogenic shock and severe marked vasodilatation everywhere. And also cardiac dysfunction also can be due to multifactorial reasons. So for hypovolemia, the first line is always, of course, crystalloid resuscitation. And second line, if you still need to use, try to avoid, but if you need to use, you can use colloid, gelatin-based. And you need to avoid starch-based HES. I don't think it's available anymore anywhere, because when they use starch-based before in a study, they is shown to have higher kidney graft failure. So when they transplanted the kidney to the other patient, the kidney function is not as good. It's not that good. Okay, the graft failure is quite high. Okay, so for the vasodilatation in something like neurogenic shock, like I told you before, the first line agent is noradrenaline. It's the best agent to increase mean organ perfusion pressure. It's a potent alpha-1 agonist and some beta-1 agonist action. And for cardiac dysfunction, you need to correct other factors first, like hypovolemia correction, SVR correction with noradrenaline, and electrolyte imbalance correction. All right. So for volume, you need to target euvolemia. It's an ideal but arbitrary target. But you try to the main concept is try to avoid so much use of the fluid. So we want to avoid fluid overload. And some authors still say if CVP is used for guidance, aim CVP less than 8 in general. But many centers not using CVP as a guidance anymore. And fluid restrictive strategy seems to benefit almost all organs, provided other hemodynamic targets achieved, like good perfusion. Okay, all hemodynamic perfusion target like lactate, CRC, capillary refill time, and so on. So fluid restrictive strategy has been shown to have no effect on kidney graft outcome. So previously, the thinking is that when you want to do kidney transplant, you need to overload, give a lot of fluids to the patient. But now the latest evidence say fluid restrictive strategy is as good as a higher positive balance of fluid, because a higher positive balance of fluid, you can also cause kidney renal edema and can cause further worsening of kidney function. Okay, and for the vasodilatation, after the first line of noradrenaline, you can don't be afraid to use catecholamine, because the previous teaching was try to avoid catecholamine only. No. The latest evidence say you need to use catecholamine, you need to use noradrenaline, because the thinking is that it's like a neurogenic shock, loss of sympathetic tone, loss of central sympathetic outflow. So of course you need to use catecholamine, and then the first line is noradrenaline. Okay, so next one is, like I told you before, if you are going for heart transplant, especially for heart transplant, untreated autonomic stomp is the highest risk for graft failure. So you need to treat the autonomic stomp promptly. Okay. So the old thinking is that don't use catecholamine in the sympathetic loss period. No, it's not true. So now we need to treat the autonomic stomp. We need to treat the hypotension when it occurs. Okay, so vasopressin was popular and supported by the large OPTN trial, but this trial was non-specific observational with no proper analytical comparison. And the vasopressin initially has been thought to be the first line in brain death and organ donor maintenance, but the benefit is like is spare the use of beta agonists like noradrenaline and so on, but the the mean organ proficient pressure is not as good as noradrenaline compared to vasopressin. Okay, so when the current thinking is that you start with noradrenaline and you need to use another vasopressor. You can use vasopressin, especially when the diabetes insipidus manifests. Okay, and then for cardiac dysfunction, you need to optimize noradrenaline dose to improve cardiac proficient pressure. If after all the other corrections have been done, noradrenaline has been optimized, you can use dobutamine. Dobutamine is preferred if cardiac dysfunction persists in this phase, but you need to avoid excessive dose due to increased myocardial oxygen demand. And especially for heart transplant, you can delay or repeat the echocardiography later in case of deciding for heart transplant, because sometimes the cardiac dysfunction can be just transient and temporary, and the LVEF may recover later, and so you don't want to disqualify the heart for transplantation. Next is mechanical ventilation. If you went through my talk yesterday, the general goal and phases of mechanical ventilation, these are the general goal. So in brain death patient, we also use the same lung protective strategy, because up to 15% of brain death patients have ARDS. They also have neurogenic pulmonary edema due to autonomic storm. They have pro-inflammatory period. They are having inflammatory mediators is high. They might have nosocomial pneumonia because they need about 3 to 4 days to settle the organ donation. So the same criteria applies. You want to be on the safe side of the mechanical ventilation. You want the diaphragm pressure to be less than 15, tidal volume less than 6 ml per kilo, blood pressure less than 30, low autopsy and low mechanical power. And on top of that, on top of the lung protective strategies, like you will do for ARDS patient, CPAP can be used for apnea test to prevent atelectasis trauma, atelectasis injury in the patient. And the studies have been shown methylprednisolone may help, as it had been as steroid is helpful in the ARDS patient, is as well is the same thing for brain death. Methylprednisolone helps in reduce the inflammation and reduce the ARDS in brain death patient in lungs that is going for transplantation, as well as reducing the inflammation in other organs to improve graft success in other organs. So lung protective strategy, methylprednisolone and CPAP used for apnea tests have been shown to improve lung transplant graft success. So next is electrolyte imbalance. The main electrolyte imbalance in brain death is actually hypernatremia. This can be due to diabetes insipidus because of the hypophysis, the pituitary has injured, infarct and ischemia, and loss of antidiuretic hormone ADH. So it can lead to loss of free water. And when we resuscitate the patient, we are giving chrysoloid containing sodium, chrysoloid which contains sodium, like normal saline, the very high sodium. And we also give osmotic diuresis in traumatic brain injury when there's neurosurgeon trying to treat the patient. And these three can cause polyuria as well at the same time when the patient having hypernatremia. Okay. So at the same time, when these two occur, hypernatremia and polyuria, there will be hypocalcemia, hypomagnesemia, hypokalemia, hypophosphatemia. So easy to say, other than high sodium, the rest is low. And all of this, especially hyponatremia, if you don't treat them, it is a negative factor for graft function for both liver and kidney. Okay, so I've seen it before in some of my patients when they're brain death. If you don't treat the hyponatremia aggressively, it can lead the kidney function can worsen just like that, especially in a brain death patient. So this is also a negative factor for graft function, means after the graft has been transplanted, the function is not as good. So for diabetes insipidus, you can treat with the desmopressin once diagnosis is made, 0.5 to 1 mic every 6 to 8 hours or 1 mic every 12 hours. We titrate the dose to reduce the urine output to 1 to 1.5 ml per kilo per hour. So you can either half the dose or you can prolong like every 24 hours if you have the urine output already achieved. And another way is to treat hypernatremia is you want to aim to use balanced crystalloid since beginning. And once you can see the hypernatremia sodium trend is decreasing, you can use free water or glucose containing solution, because it's patient. We are not caring for the brain anymore, right? So we anticipate polarized effect and treat vigilantly, and correction of electrolyte targeting normal values. So conclusion is correction of electrolytes, prompt treatment of diabetes insipidus, and will concurrently help organ perfusion. And this will improve yield of organ donation. Okay, how about hormonal therapy? So desmopressin to treat DI, yes, we know. Methylprednisolone and other steroid to reduce inflammation cascade and improve lung transplantation, as well as kidney and liver transplantation. How about thyroid hormone? Okay. So thyroid hormone in a brain dead patient in a baboon model by Nowitzki again, T3 depleted rapidly and body switched to anaerobic metabolism, and this action will be reversed with T3 administration in this baboon. Unequivocal result from studies, some shown not helpful, others found it may reduce inotropic need and improve allograft function. Okay, this is in human. Yeah. Okay. So in an RCT by Venkateswaran, Australian intensivist, it has been shown that T3 shown similar outcome in terms of inotropic support and allograft outcome. Okay. So Venkates shows that even if you use T3 or you don't use T3, you don't treat the hypothyroid problem, the allograft outcome, the inotropic support is similar. It doesn't show any difference. So you don't need to use thyroid hormone, in the brain dead patient. Okay. Most studies, when they use T4, absolutely no improvement in outcome. Okay. T3 is multiple times more expensive. The one that has been shown to work in brain dead patient is T3, but it's multiple times more expensive. T4 doesn't work at all in the brain dead patient, because they say in brain dead patient they have a problem in peripheral conversion from T4 to T3. So this is the reason that they thought the T4 is not going to be useful. If it is going to be useful, you need to use T3. So thyroid hormone, T3, in consensus all over the world, is not widely used, and only for last resort in hemodynamic instability, after all other management have been given, and the likelihood of good allograft function in the patient and for the organ to be transplanted. And next is body temperature management. When the patient becoming brain dead, they call this donor poikilotherma, means the body core temperature 100% follows the temperature of the surroundings. And this is due to hypothalamus loss from infarction and ischemia, and as well as the total fall in metabolic rate and reduced muscle activity, the muscle not moving anymore. And also due to peripheral vasodilation, which can cause heat loss. And the body temperature can drop. I have seen drop until 33, 32 if you don't do anything. So you need to monitor core body temperature continuously. You need to prevent the heat loss by using blanket, forced air warmer. And you need to give also warm infusion fluids. AIM normotomia is possible. Some small studies do indicate benefit of mild hypothermia for expanded criteria kidney allograft. Expanded criteria means the marginal kidney. That means probably maybe like a creatinine 150, 180, but still you do kidney transplant. This is called expanded criteria, an old elderly patient. So in expanded criteria kidney, marginal kidney, some small study do indicate benefit of mild hypothermia around 35 degrees Celsius. Otherwise, you just aim normothermia around 36, 38.5. Okay, other management in brain dead patient to maintain the organs. And the problem was hyperglycemia is very common. It is due to sudden elevated insulin resistance. When they study the brain dead patient, the patient going for pancreas transplantation, they saw the elevated C-peptide over glucose molar ratio. This is one of the surrogate marker of insulin resistance. At the same time, it has been shown that the body suddenly reduced the insulin level production. And on top of that, when we treat the patient, we want to correct the hyponatremia, we give glucose containing fluid. And patient, of course, has been given enteral feeding via rice tube. And at this point of time, you need to treat the hyperglycemia, because hyperglycemia is bad for the allograft function. Okay, you need to give insulin, and you want to aim the glucose between 6 to 10. This is especially important for liver allograft, because when we take out the liver, if you don't properly give insulin and glucose, the glycogenolysis will occur and the liver will lose its glycogen stores. So when you do this, when you give insulin, when you give, of course, the glucose is there. You need to give insulin for the liver to take up the glucose, and for the glycogenesis to occur, it will re-glycogenate and providing fuel source during ischemia time for the liver. Ischemia time, when they take out the liver from the body, from the donor, this is called ischemia time. And the insulin allows organ to take up glucose as fuel for metabolism. Next is enteral nutrition. This is conflicting recommendation by expert. Animal models using rabbit, porcine, and rat shown enteral nutrition improve allograft function for liver and kidney. But this benefit studies have been done multiple times. It's not replicated in human in randomized trial studies. So the current recommendation is to stop enteral feeding, because loss of vagal tone when the medulla died will severely affect intestinal transit, intestinal movement, and we will reduce significantly absorption of nutrients. So when the feeding is not being tolerated, the bowel is not moving, there is a high risk of there will be high risk of residual gastric volume, and patient may the vomiters will come out and will complicate the other management of the organs. And of course, but at the same time, if you stop the enteral feeding, you need to give glucose solution. So glucose solution required for the organs, plus insulin for the organs to be able to take up the glucose. So we aim to aim 6 to 10. So transfusion threshold, enough to ensure good carrier of oxygen content. Hemoglobin generally recommended more than 7. High, but some consensus target higher for thoracic organ, more than 10. Platelet target more than 50. Normal NRPT, APTT. This is aim to just enough to prevent significant blood loss during procurement. Okay, this is due because to avoid hypoxia due to blood loss when the surgeon is procuring the organ. So it's not after they procure the organ, it doesn't matter anymore. So blood investigation, HLA typing, blood types, viral workup prior to any blood and blood product transfusion need to be taken before giving the blood. Of course, this common sense. So how about optimal time to manage? Faster procurement, when patient has been detected, brain death diagnosis have been done, faster procurement, shorter time donor management, it does not equals to good outcome. Fast does not mean good. So in a large cohort, 1,000 patient renal transplant recipient, longer duration of brain death means the longer time taken to optimize the renal function in the donor was associated with improved initial graft function and graft survival. Okay, so you need to take your time to optimize the donor. Okay, don't make it fast, don't hasten the process. They suggest that the time taken to optimize donor cardiovascular status may reduce ischemic injury in the donor. So optimal time to manage is very important. Optimize organ function first before proceeding with surgical procurement. But of course, but they do not do any unnecessary delay, because it's comfortable for the family. Family knows the loved one already died, so you don't want to delay it unnecessarily. So how about the clinical provider? Who is the one important to manage organ maintenance? Organ maintenance need to be done in ICU because it involves multifactorial, a lot of management, a lot of care need to be done for the patient, for the donor. And it's crucial to be intensivist led, because in the studies done before, is increased number of organs recovered for transplantation, double the number of organs in total, increase in number of lungs transplanted, triple, increase in the number of kidneys, double, significantly increase in heart and lung transplant. So it needs to be done in ICU. You need to get an ICU bed. You need to involve and involve intensivists in the management of organ maintenance for organ procurement. So for summary, time, you need to start organ donor maintenance since the patient identified as early as possible as potential organ donor. You need to take your own optimal time, to take some time to aim to optimize the physiological state prior to surgical procurement. Don't rush. Okay. Hemodynamic, autonomic stomp, you need to treat it if present using short-acting drug. Sympathetic loss, you need to give fluid, noradrenaline, vasopressin. Okay, IV vitamin is needed. And metaprednisolone, you need to give early. This is, now we know it's beneficial to give early to control inflammatory reaction. It won't affect the immune function, it won't affect the HLA typing and so on, so it doesn't matter. And lung protective strategy, of course, for the benefit to improve lung transplant success, as well as to improve the oxygenation and hemodynamic status for the other organs. You need to maintain normothermia, you need to aim normal glycemia, don't forget to give insulin, otherwise the body cannot take up the glucose. And thank you. So I hope you guys benefit from my talk, and we can lead to better organ donor maintenance in organ donors. Thank you.